In addition to EMCast, a subscription to EMedHome.com includes over 1,000 video lectures from the best EM conferences, with more added all the time. View on any device whenever and wherever you want. All this and so much more, including hundreds of CME credits each year for the low cost of only $99. EMedHome.com. For 20 years, the homepage of emergency medicine. Subscribe now.
Greetings, everyone, and welcome back to EMCast. This is Amal Mattu at the University of Maryland School of Medicine, and welcome. Well, we have a very special issue of EMCast for you. A lot of listeners have been asking for some extra information about COVID, and in particular, they haven't specifically been asking about medical information about COVID, but some of the non-typical medical type of stuff. For example, people have been asking about how do you prepare for COVID? In many places around the country, the surge hasn't hit, and people who are waiting for the surge to hit are looking for tips from places that have already been hit with the surge. For example, New York City. And they're looking for information on how they can prepare. People have been asking also about how good testing is. People have asked about what it's like to be quarantined. And finally, people have asked about some of the insiders' views from some of the emergency departments and ICUs. So what we've been able to do is get some of our graduates from the emergency medicine residency program here who are in some of those hotspots, and I've been able to hook up with them and interview them about some of their experiences. So we've got 3 people that are going to be joining us this month to talk about their experiences. We're going to start out in the hotspot of the United States, New York City, with one of our graduates. He's going to talk a little bit about ED preparations. Then we're going to go down to New Orleans and talk to one of our graduates who probably had COVID. She's going to talk a little bit about what it was like to be quarantined. And then she's going to talk about how useful are the tests that we're actually getting on patients. And then we're going to go back to New York City and get an insider's view from another one of our graduates who's working in a very, very horrendously busy ICU in New York. And again, we're going to learn a lot more about COVID, not necessarily just from a patient treatment standpoint, but some of the surrounding issues that have to do with COVID. Now, once again, because of social distancing, I'm having to do these recordings from quite far away over the computer, so the audio quality is not as good as our normal EMcasts. I hope to get back to what I refer to as social narrowing eventually, but for now, we are far away from our folks, and so please excuse the audio quality. With that, let's go ahead and get started. Well, kicking things off is going to be Dr. Josh Moskovitz, who's a graduate of our emergency medicine residency program from 2010. Josh actually not only was a fantastic resident when he was here, but he was also a former president of EMRA during the time that he was in our residency. So he was one of those guys that did a whole heck of a lot more than just the residency program, which we love to see. Now he is back home in New York, and in the middle of all of this COVID crisis that every one of us are hearing about on TV and radio and social media, Josh works at Jacobi Medical Center in the Bronx. Jacobi is a very famous medical center. It's, Josh, you said it's the oldest medical center in New York. Is that right?
It's the oldest emergency medicine residency in New York.
Yeah. And he's part of the Albert Einstein Montefiore Emergency Medicine Residency and an adjunct assistant professor of emergency medicine at Hofstra as well. And at Jacobi, he is associate director of operations. So he is really very much involved in the COVID response in his hospital. And so we all want to kind of get an inside scoop about what's going on up there. And that's one of the reasons that I wanted to get Josh on board. So first of all, Josh, welcome. It's great to catch up with you a little bit before we started the recording and to hear about how things are going. But just let me throw things over to you. And I just have 3 very simple questions. I'm going to be asking you kind of what kind of stuff that you guys did to prepare. Or first, we'll start out with what you're seeing right now, and then maybe we'll talk about any tips that you have for other people that are kind of waiting for the surge. So tell us a little bit about what kind of things you're seeing in your hospital right now during the past week or so.
So this has been, well, thank you, Amal, for having me. First of all, it's a great pleasure and great honor to be on here with you. It feels so long ago that residency has ended. This thing has been it's been an experience, to say it simply. You know, it kind of snuck up on us faster than we expected. The part of the hardest hit areas in the country right now, and kind of the first really hit areas in the country besides Washington. And it really was it went from nothing to full throttle it would have appeared seconds, honestly. And so I wish we had more time to prepare. I wish we had more time to make decisions ahead of time. And I hope that this is a learning opportunity for everybody else to give you the opportunity to better handle than ways we could have done and learn from our lessons as well. I'll tell you that what's super surprising for me in general was how it just slid under the radar in a certain way, that patients we never anticipated having it are having it. And so one of the lessons we learned is we were very aggressive at Jacobi and early into this, I think earlier than our peers, was testing every patient we were admitting. We tested every patient we admitted, and you'd be shocked at the people we found positive. The patient that comes in with syncope who broke his ankle. And the only reason you admit this guy is because he's got a broken ankle and needs surgery. We tested him, and everyone laughed at us, and he came back positive.
So not even fevers and shortness of breath, but just everybody, huh?
It's everything. It's diarrhea. It's loss of smell. It's loss of taste. It's muscle aches. Fever, I feel like, is one of the least reliable symptoms for us because we're seeing a lot of these 99 and change temperatures that are being admitted as sick as can be with a 99 temperature. And so I think pulse ox preferably has been our biggest screening tool. While not perfect, when you're seeing a mass influx of patients, it's super important to find a quick and rapid, easy way to do it. But I tell you, the screening early, I think, helps us a lot because I think what a lot of our peer hospitals might have experienced is when you have these patients that are admitted and they go all over the hospital for an ultrasound of the kidneys, a CAT scan of the lungs to better differentiate why the oxygen levels were off, and you didn't realize they're COVID positive. And now the elevator and the hallway and the CAT scanner were all exposed.
Oh, gosh.
And I think that's what led to this rampant spread in other facilities. And part of it was luck for us, and part of it was pre-planning, that we were aggressive in early testing of all admitted patients when they came into our facility.
Okay, so it sounds like there's not even a clue that tells you, this is the person I need to worry about, and maybe this is somebody I don't need to worry about. Just anybody who's sick enough to be admitted, bam, you're getting the test on them. So. I
don't think that the data is out yet to help determine that. And one of the things we're starting to do a deep dive on now with Jacobi, we're starting to pull our data, is to try to see, well, what are the prognostic indicators of who needs to be admitted, who needs to come back, who ends up on a ventilator? Of the people we're intubating, who is making it off, who is sicker? And that's what we're starting to do a deep dive on the data now. One of the hardships we had in the beginning, our normal operating volume, we're chugging along. We're a city hospital, part of the largest public health hospital system in the country. And we're chugging along on a regular day is hard for us. And all of a sudden our volume goes up 20, 30, 40% because of COVID. What do you do? And we were fortunate we got a tent up early enough for us that we were seeing, I think at one point, 75 patients a day in our tent outside the emergency department, 75 patients a day.
Wow.
And what we had done was we structured almost like a car wash, right? You had a greeter out front, a PA or a nurse practitioner or a registered nurse who would greet the patient upon walking into the ED to assess for criticality. And what was so remarkable is these patients would walk up the hill, they'd look fine, you'd send them in the tent, and I'll tell you, the spoiler alert is their pulse ox was 85%. And you would never guess just by looking at them. So they would greet the patients, we'd get them in a tent, we'd get them registered, they would hit a nursing station, get a rapid triage, and they would hit a physician station, whether it was a PA, a nurse practitioner, or a resident. And in the beginning stages, I'll finish out here, and then they would hit the attending physician. And the attending emergency physician would go from line to line. At one point, we had 3 rows of traffic going, and the attending ED physician would oversee all 3 lines, just kind of saying yes or no, I agree or disagree. And we were fortunate in that our hospital partners, our residency partners in the facility helped us get through this. So in the beginning, we didn't have any external support. So we were using OMFS residents, dental residents, pediatric residents, nurse practitioners from the internal medicine ambulatory care clinics to help us staff these lines with the EM attending overseeing the process to make sure we had a quality control situation going to not miss anything of criticality. And the beautiful thing about this tent was, for us at least, I'm curious what other people's experiences are, is we were able to disposition home right from the tent 90% of patients roughly, if not higher sometimes. And what was so essential for this was it prevented 60-plus patients from walking into the ED and occupying a room, requiring a terminal clean, interacting with 10 to 15 to 20 staff members along the way that really jeopardized a lot of people. And I believe that was a big reason our staff didn't get as sick and were able to maintain as much of operations as we did.
Yeah, so just to kind of nail things down a little bit, let's kind of take on the role of the patient. Let's say a patient is going to come into the emergency department. when they show up to your hospital, or if they're planning on going to the emergency department, the first place they end up going to, they're directed to these tents. Is that correct?
Yeah, so the way our facility is designed, and I can share pictures if you'd like, is there's a hill that people, if they're driving by car, they would drive up or walk up if they're taking public transportation, which is a large part of our population. We have a very similar patient population as Baltimore does. And so they'd walk up this hill, which is actually good because it was a stress test for them. By walking up this hill.
So everybody's hypoxic when they get to the top.
Serious, but that was the biggest thing for us, because if you're just sitting there resting, you'd be surprised our pulse ox is 95, 98. You can walk up a hill, and you're like, holy geez, it's 85%. I would never have guessed that. And so that hill was very helpful for us in that it stressed them just enough that this 25-year-old comes in, you're like, why is your heart rate 135? That's really peculiar. And then you pause for a second, you get the pulse ox, you're like, oh my goodness, you're 85%. But you look fantastic, and they're talking in full sentences.
So they come up this hill to the tent, and then they get a quick screen by the greeter and the other folks you're talking about, and they're kind of overseen by an attending. And is that quick screen, is that kind of like a medical screening exam to decide whether they go into the ER proper or they go somewhere else, or what exactly is happening? What is the greeter and that initial evaluation intended to do?
So the greeter, we use, I believe, a nurse for the most part, because at this point we had the extra capacity there versus TA in the beginning. And the greeter is very similar to the nurse in front of the ED who, greets every patient as the first clinical person to decide, is this person look sick or not? And that person would say, if they look really sick, they go right into the ED, traditional triage process. If they don't look sick, they would say, what are you here for? I'm here for a medication refill. Oh, I fell and hurt my ankle. Okay, traditional triage process, go into the main ED. If you're here for anything that's sounding COVID-y, which, like I said before, could be anything, then they put you in the tent if you looked well enough to go through the tent, which also meant you have to be able to walk. Then they hit a registration clerk. We use Epic in our facilities, so it would open the visit for us, make it easier. And then the next spot would be the nurse, almost like car wash, like wash, soap, rinse, and exit. And so the nurse would open a rapid triage. We had a way of tagging these as a mass influx patient. And then they would hit the resident or the mid-level or resident or NP station and get, vital signs done and get assessed and then present to the attending. And the attending would walk between the three lines saying yes or no. And one of the such things.
Right. And
yes,
when they're saying yes or no to what?
To the going home or going to the emergency department.
Got it.
Is this patient safe for discharge, or does it need further evaluation? And so we also built into Epic, we built in a quick note, essentially a COVID smart note that essentially allowed us to write a full emergency department note in under 2 minutes. So it pre-populated, pulled in the pertinent details, attached discharge instructions, et cetera, so we can get a patient through in about 15 minutes, essentially, from door to finish, a full ED visit. And the same part of this is if the patient ended up in the emergency department, we found that our patients who ended up in the ED were being admitted from the tent at a rate of about 90%.
Wow.
So the tent saw you and said, you need to go into the ED. The probability of that person being admitted was about 90%. And we're looking to hopefully pull the data deeper to see what are the commonalities and hopefully try to publish that at some point.
Wow. And you mentioned that hypoxia was a common tip-off. I've heard the term used by some other people, happy hypoxia. So the patient looks pretty good, but they're just hypoxic. Maybe they don't look great, but they certainly don't look as short of breath as their PO2 would suggest. Is that right?
The PO2 and the x-rays are horrible clinical correlators. And so I noticed early in this disease, our resident's like, all right, I'm going to admit this guy. He's got multifocal pneumonia. And I look over at the bed and I said, he's texting on his cell phone. He looks fantastic. What are you talking about? And so this is not your bacterial pneumonia that you would see back in the day. They're like, oh, my God, this guy's going to have a horrible outcome. They're sitting there smiling, chit-chatting with this horrible x-rays. And so, we had this massive influx, and we had to be smarter about our management. We had to really kind of fine-tune our processes to figure out what is the best way to – who do we keep, who do we send home? And I by no means have a perfect answer for you now. I'm hoping to look at data and see what we have. But it was very interesting to see how fast our practice had to change and adapt and evolve.
Yeah, I've heard people saying that they've been sending home patients with multilobar pneumonias like they've never done before because they look good. And also I'm sure that's related to the shortage of beds upstairs and resources. And so people have been very surprised at the number of pneumonias that they're sending home simply because the patients look good. Is that something that you've been finding also?
Yeah, and the question then becomes also, is it acceptable to send someone home to come back? Back in the day, we used to stress these 72-hour, 40-hour return visits as being negative, but our treatment is so limited at this moment, right? It's really the only proven treatment is oxygen and observation. A lot of the stuff is investigational at this moment, and so is it wrong to send home a 30-something-year-old with a little hypoxia as well, and he comes back 2 days later feeling a little worse? These are the questions we have to ask and really identify who needs further intervention. We were really stuck in the beginning. Our ED, has a boarding problem like a lot of other emergency departments do. But we found during our surge, we were up to, 75, 65 boarders in our emergency department. And so we had to really find some non-traditional spaces to really manage patients and to really offload our ED to allow us to continue to take care of resuscitations as they came in.
Right. Who's getting tested? You said initially that everybody who gets admitted is getting tested. Are there other people also that are getting tested? And also, are you using the tests in any way of deciding who goes home versus who stays? No. So testing is still a challenge for us in New York City, and every health system has a different process. They have different vendors. What is the reliability of your test? What is the turnaround time of your test? And it's still a challenge. And in the beginning, ours was really, really limited. When this first started, being one of the early people dealing with it, we were limited to the Department of Health. And then eventually they got a private vendor on, and then they got another private vendor, and everyone's trying to develop their own in-house tests. And, until we really get our own in-house test ubiquitously, that's rapid and highly accurate, it's challenging. But tests can still take a few days to come back, depending when it's sent. The false negative rate is still very high. I don't know the facts offhand, but I don't think it's reliable enough yet. I have a colleague of mine that we accepted as a transfer who was very, very, very sick, and his COVID test was negative. His X-ray looked horrendous. His vibe values were consistent with COVID. His vital signs were consistent with COVID, and it wasn't until the second or third test came back that it was finally positive. And so we have to be distinct about it. The advantage for us was the Department of Health came out eventually and said, in New York City, do not test patients you're sending home, only test patients you're admitting. And that was very helpful for us in New York City because it really dropped down the worry to well from showing up in ED for a test. It really mitigated that response because I'll tell you, if all of New York City decided to show up to ED for a test, we would have been destroyed. We would have been in a lot of trouble. We ran out of swabs at one point because we were admitting and testing so many people. And it's, we're not used to this level of volume. Yeah. In terms of the patients coming into the emergency department, who I guess by virtue of them actually coming in from the tent, they probably look relatively sick. And on top of that, you said 90% who make it into the ER end up being admitted. Are you having a lot of intubations in the emergency department right off the bat and boarding these patients?
I would say, so the thing is they don't always look sick. That's the scary part, right? Sometimes they look just fine. And you're like, oh, my goodness, your vital signs are terrible. What is going on here? Some of them are more predictable than others. Okay, you're in your 60s, you're diabetic, you're hypertensive, you have asthma. Okay. But the 20-year-old comes in, you're like, I don't believe my eyes. Like, you're talking to me in full sentences. You say you feel fine. Your pulse ox is in the toilet. So it's hard. I think the pulse ox and the heart rate, to me personally, anecdotally, when I see a normal temperature and a high heart rate, I get nervous, and that's when I really dig a little deeper. When they come in, we were probably intubating more in the beginning than I would have liked. I think we've learned a little bit to try to be aggressive in proning because that seems to be the only consistency we've found so far. Proning, there's still a lot of confusion for us, I think, on what is safe practices for PPE-wise. So can you put high-flow nasal cannula? Can you put BiPAP? Can you intubate? What is the risk provider? I think a lot of this is still very unknown, and that's why I feel a lot of panic about it. And so in the beginning, we were very, very hesitant to high-flow someone or BiPAP someone because we were afraid it was going to expose people to unnecessary viral pathogens.
Yeah, we had heard about that. And in fact, Mike Winters and Ken Butler did a podcast for EMedHome just probably at the early part of March about all of this. And at the time, the prevailing thought was to intubate early, try to avoid BiPAP, CPAP, high-flow nasal cannula. And it's interesting how just within the past week or two, the thought about that has really been changing quite a bit. Largely because of what we're learning from the Italians and also the folks in your neck of the woods in New York.
Yeah, personally, I'm not a fan of intubating early. Like I said, I don't want to speak too much because I don't have enough evidence or data. I think this is too new. But, we're seeing it's really hard to get people off the ventilator once they're on there. The level of sedation required is tremendous and difficult and challenging. And so we're trying every alternative thing. But I'll tell you, the proning thing is amazing. I watch people's heart rates go from 135 to 105, and I watch their stats go from 86 to 97% just by laying on their chest. It's really remarkable.
Right. In terms of the PPE that your providers are wearing, obviously I'd assume that everybody in the emergency department itself is quite donned. But what about out in the tents? Is it just mask and the shield over the eyes, or is it the full PPE or PAPRs? Or what are you guys doing out in the tents?
I mean, the whole thing is just hard. It's hard. So first off, being a New York City hospital, a lot of us utilize every available space. People use hallways for spaces. They use rooms with curtains. Not every room is walled off with a door on it. So it's really, really challenging in New York City. And like I say, the company, because I've worked in a lot of hospitals here in the city, and they're all very, very similar. So I'm not singling anybody out. It's challenging, and there's a big confusion on what is proper PPE, what should you wear. When this first happened, there was a big, massive run on PPE, and one of the lessons we learned was we have to lock the PPE up very quickly. People stole so much stuff in the beginning, just grabbed stuff because there was panic, there's pandemonium. It's no different than people robbing toilet paper from every drugstore they go to right now. The same thing happened in the hospital. And so we were very lucky in that we established a command center that mandated you show up for your PPE to get your PPE, and you only got the day's worth. And you couldn't get for your friend. You only got for yourself. You had to explain who you were there for. So if you were a consultant, you couldn't just come into the ED and take PPE. You had to say what patients you were there for. And that really saved us by making sure all of our staff had the appropriate gear. You know, in general, the amount of PPE you're going through is a high burn rate. One of the big problems that I have with this disease is we treated it like Ebola when we first started, you know, where everyone gowned up and 3 people wanted to watch you and you went to doff it. That's not possible when you're taking care of 30 patients per provider, because it's not the other way around like Ebola was, where it's 30 providers per patient. And so it's very different. In the tent, because it's a very segregated area, it's very separate from the ED, we can be a little more strict about it. And so it was nice that I was able to mandate really aggressive PPE in there. You don't come to my tent unless you're fully donned. There's no ifs, ands, or buts. I threw you out if you try to get in there without it. We did the approach where we use an N95. We put a surgical mask over it because we were having to reuse N95s, unfortunately, for a little bit as we secured our stockpiles.
Sure, as we all are.
Yeah, eye protection, gowns, etc. Really protecting. And I thought that was good. But when you're in a tent, it's easier because you're in an austere environment. You're constantly reminded you're in it. It's separate from the ED. When you're in the ED, people get very relaxed about it. And then you have people who walk through the ED, whether they're consultants from the floors or other people who aren't as involved. And it's challenging. I think one of the things you'll learn, and I've heard this at university or other hospitals, is people will start to wear their own PPE that they get on their own. And you'll see people walking in a bubble suit or a Tyvek suit or a Chemex suit. And, you know, I don't think they understand those individuals and necessarily how you wear it, how you take it off, and what the exposure is. And that's part of the challenge. And in the ED, with the constant moving parts of coming out of rooms and going here, going there, it's so much harder to control. And I don't have necessarily great answers from that other than wishing everyone else the opportunity to really try to group think it and plan ahead if you can.
Really interesting. Well, this is all really great stuff, Josh. Before I let you go, I have one last question, and you can go on as long as you'd like about this one. But if you could go back a month, knowing what you know now, what would you do differently? And this alludes to what kind of tips you have for people that maybe are a month behind you guys. What would you do differently?
You know, I would say that you need to develop an in-house test somehow, and this is not ED-centric, this is hospital-centric, but you need an in-house test that's reliable and relatively rapid turnaround and reproducible. And I would really honestly recommend testing people who you're admitting ubiquitously because there's no harm. What you can't do is you can't then say, like TB, we're going to isolate till our test results are back. That's not practical. You'll shut down your ED operations. So you do need the help of infection prevention to partner with you on being rational about this. I would say that when your surge hits, you have to stop this idea that you're only going to cohort COVID-positive patients. Because in the beginning, it was taking us 4 or 5 days to get test results back, and the test results were 30% false negative. I cannot wait to cohort because everyone has it. So that was a big primer for us. Be smart with your equipment. I'm not saying to hoard it, but you got to be smart with it. What are you going to do? How are you going to do it, et cetera? We redesigned our airway boxes to include gyroscope blades because we're trying to avoid direct laryngoscopy as a result. I wish we did a little sooner. Our supplies were a little lean because my experience is residents love to use gyroscope over direct laryngoscopy these days. And as a result, our stockpile was lower than we would have liked to have been at the start of all this, which made it very challenging. Fortunately, we did not run out, but I've heard of people coming dangerously close to running out of that equipment. PPE, you can't review it enough. This idea of twice a year doing an Ebola drill is not enough, and this is not Ebola. This is very, very different beast. So you have to find a method that allows you to feel comfortable. At some point, your hospital will become completely COVID. I can't remember the last time I saw a patient that wasn't COVID, honestly.
Wow.
The saving grace for us is our volume is way down. We're at 50% of our regular volume right now, but our admission rate is like almost 50% right now. So it's much higher admission rate, much higher admission absolute number, much higher criticality, and much higher expiration. I'm signing more death certificates than I would care to admit. But the overall volume is down, which was a save. Form partnerships now with your off-service people. It's okay to use people who aren't traditionally involved in emergency medicine in the tent. I said we had pediatric residents helping us with adult patients in the tent. And it would not have been possible to have been successful in the tent if it wasn't for those colleagues. While we had the EM attending overseeing the process, their involvement was critical to the success of the ED. And you really need to identify non-traditional areas now to max, as well as ICU areas. These patients are spending time on vents much longer than normal disease. Well, normal disease, 2-3 days on a vent, 2-3 days in an ICU for the most part. Now they're spending 11, 12, 20, 30 days on a vent. And so finding places to increase your capacity is so, so important. We built a wall in our waiting room and turned half our waiting room into an overflow area. And that was challenging because we had to use portable oxygen tanks, which don't last very long. And so we had to screen people for low criticality who were not safe for discharge, who were admitted, and they spent 3-4 days in that area, which wasn't ideal. But without that overflow area, our ED would have fallen apart. It would have crumpled. And so we eventually started putting patients in pediatrics. As an example, we closed our pediatric ED to store sicker patients who needed wall oxygen. And that was super, super important. And then also tending to your personal issues. Your staff will get sick. It is inevitable. It's impossible to be 100% protective and being there for them. I kind of joked with you offline before we started about how I found a barber, a guy who works with us who used to cut hair, and he's cutting my resident's hair right now because, months in, you feel like crumb. You feel filthy. You want to feel like a normal person again. And when you're spending 20 out of 21 days in a hospital, it's hard to feel that way. And so, doing whatever normalcy you can to allow it. And really the public has been great here for New York. They've been doing this thing in New York where they clap for us at 7 p.m. At 7 p.m., people are going to the balconies, pots and pans and clapping. My daughter called me, "Hey, I'm clapping for you." It was, it brings tears to my eyes and gives me the little bit of encouragement I need to keep going forward.
That's fantastic, Josh. Josh, your people obviously have great leadership in you, and I'm glad that the rest of us can learn from you also.
Thank you. I'm lucky that the hospital administration took us very seriously and were very helpful. I'm lucky that the system itself has a phenomenal leadership downtown. We have this tremendous CEO who's a physician who gets it, who's like phenomenal, and he comes to EDs and he comes to the hospital and checks on us, and he understands our needs. And honestly, without them, some of our sister hospitals in the boroughs got hit much worse than we did. I mean, much, much worse. Like, you can't imagine how bad it is. And some of them end up in the news, unfortunately. And we were able to absorb 50 to 100 of their patients, I believe, to really help offload them. And that really has to do with our leadership in our hospital, really helping go above and beyond to make non-traditional spaces, hospital areas, PACU being in beds, ORs being beds, waiting rooms being beds, really expanding like you would not believe.
I'm really glad that we've all had a chance to learn from some of the things that you've been talking about. And also, I'm sure there's a lot of other great leaders at your hospital as well.
I figure as much, but I also have to give out my thanks to the people who support me as well.
Yeah, definitely. So, well, it's very gracious of you. Do you have any other things?
The other thing that people have to realize is this, part of my friends, but this sucks. It sucks to be in this pandemic. And, there are people who are upset about some of the things that are happening. And it's like, this virus doesn't care what your feelings are. They don't care what you think. It's here to decimate your lives. And so do I wish that every staff member in my ED had a PAPR to wear and I could seal my EDs with, plastic, much like that movie Outbreak back in the 90s? Absolutely. But it ain't possible. And even if you had, there's no way to have unlimited PPE that you could walk out of every room and doff everything right then and there and walk back. There's no humanitarian way possible to do that. No matter if every factory in this country was pumping out PPE at full throttle. And so I guess the question is, do whatever you can to try to contain it, to try to stem the fears, just get people comfortable. These devices were not designed to be worn all day. My residents, I look at them, their nose is all broken down. Their hands are all, scathed from wearing gloves for so long. It wasn't meant for this, but this unfortunately is the reality. And I pray, whoever you pray to, that this ends as soon as possible so we can go back to normal.
Josh, I recall that you were actually supposed to come visit us to give a lecture the first week of May, and we are not going to forget that. So once all of this is done, we're going to get you back down here to Baltimore to do that lecture, and we are going to start the lecture with maybe a glass of wine. How's that sound?
Wine or whiskey, both are perfectly acceptable to me, so you tell me.
Or both. All right. Well, Josh, hey, thanks so much for your time and these great tips. Best wishes to you. Take care of yourself and also best health to your family and your residents. And I look forward to talking to you again real soon.
Thank you. And I do want to give a shout out to my residents. They've been troopers. They've been honestly amazing. And, they are a fine group of individuals, and I'm proud to train them.
And after tonight, they're going to be better groomed than the rest of us. So kudos to you for arranging that barber. All right, well, we're going to change gears now. One of the things that Josh had alluded to was the poor sensitivity of the COVID tests. And so we're going to get into that a little bit with our next speaker. And we're also going to talk a little bit about the whole process of quarantining. What is that exactly like? Some of you have been through that before. A lot of us have not. And to get into that, I have a very close friend, Dr. Liza Thomas, who's joining us today to talk a little bit. Liza is a graduate from our residency program, actually back a handful of years ago. We won't say exactly when, but she's been attending for quite some time. She works down in New Orleans at Ochsner Medical Center. She's taken on some leadership roles there. One of the reasons I wanted to get her on board the EMCast was because she's got an interest in this particular area of COVID testing. And also, she recently went through an illness herself. Liza, as I understand it, a few weeks ago, I guess, you came down with the flu. And when they tested you for COVID, it was initially negative, and it was widely thought to be a false negative. And I guess we'll get into that. But before we get into the testing stuff, tell us a little bit about what you went through going through the whole illness and quarantining yourself from your husband and your 5 kids.
Okay, sure. So I started feeling a little bit ill. It was a Friday morning, and started feeling a little bit of a sore throat, a little bit achy, some chills and a dry cough. And that morning I had a bunch of errands to do, and I was just kind of running around. And so I didn't really think much of it. I thought, we've had a pretty bad pollen season down here, and I'd had kind of a sore throat for a couple of weeks. I thought maybe that's what it was, but the achiness just kind of got worse as the day went on. The cough got worse, and the achiness.
And this is still day one you're talking about?
This is day one, yeah. And
okay.
So the achiness just really got a lot more pronounced. And so I started thinking about a couple of patients that I had seen right after Mardi Gras. I immediately started thinking about those patients. There were like 2 patients I was thinking about in particular that, right after Mardi Gras, we had been really busy, and I had a couple of patients I had seen. One went into the ICU, one did not. They both had these bilateral pneumonias, and that was before we were testing for COVID. But while we were thinking about it, nobody met these really strict criteria that they had for testing. And so, the one that I put in the ICU, we treated him for sepsis. We were giving him nebs. We were putting him on BiPAP, all the stuff they're saying you really shouldn't be doing now, at least not, at least if you're not in full PPE, which we weren't doing. And we had him in a regular room, not a negative pressure room. So that's what I was thinking about when I started having these symptoms. As the day went on, they were getting worse. And so immediately I was like, I really should probably go get myself tested. And so I talked to my chair, and I went to an urgent care and got myself tested. And the swab that I got there, I heard some bad things about the swab, and I was like, that really wasn't that bad. And the nurse who did the swab was like, good news, Mayo's doing the test now. It's supposed to be back in 24 to 48 hours. Somebody's going to call you, but you really should go home and self-isolate. And so
this test was sent up to Mayo to get done. Is that right?
Right. That was the very first day that we were no longer sending them to the state, and that the Mayo Clinic had just started this brand new test that Mayo had. So that was the good news, is that it was going to come back a lot more quickly than the state had been doing them. So we thought. So that was a Friday afternoon. I came home. I sent my nanny home. I told my kids, Mommy's sick. I'm going to go close myself in this room. And yeah, so you kind of said a little bit about my house. I'll let you know a little bit more. So I have 5 kids. One is 14 years old. I have a set of triplets who are 13. And then my youngest is 10 years old.
Oh my gosh.
And then my husband is a general surgeon in private practice. So my house is busy. The kids are older, so they should be able to fend for themselves, but they do have a nanny that they rely on pretty heavily. But I sent her home, and, I didn't give her too much information. I didn't want to worry her, but I told the kids I'm going in this room. And the room that I sent myself into is a room that they like to go in a lot because it's our computer room. And so it's a room that they come in to play games, and there are Nintendos in there and that kind of thing. But it has a bed. It's kind of our guest room too. So
sure.
So my husband and I decided, well, this would be my room. There's a bathroom adjoining. We told the kids, don't use that bathroom. It's the only bathroom downstairs. So that was kind of a problem. It also meant that all 5 kids had to use one bathroom upstairs. And so I tried to self-isolate myself in this room. I did have an N95 mask that I had brought home from work. And so if I did have to leave the room, I would put that mask on when I would go into the kitchen, and I would try to kind of retrace my steps with a Lysol wipe. If I touched a cabinet knob, I would wipe down that cabinet knob or the refrigerator door and wipe that down, and the water cooler, wipe that down with the Lysol wipe, and try to do that. But yeah, it wasn't too much of a problem staying in that room at first because I felt pretty awful the first few days.
Mm-hmm.
All I wanted to do was lie in bed. I felt pretty achy. I never really had the real high fevers. The highest I got was 99.4. But I felt like I was running a fever. I kept checking my temperature because I was like, it's got to be higher than that. I felt febrile. And I had the cough. The sore throat didn't last too long. It just lasted a couple of days. But by day 4, I started feeling really short of breath. And
Really?
I first noticed that when I was talking on the phone. I had a lot of people calling and texting me, not because they knew I was sick. I'm sure everybody's experienced this. Just, being in emergency medicine, I had people reaching out to me that I hadn't heard from in years, which was really nice. It's, kind of hard to keep up with all those texts. But some people would call, and I couldn't be on the phone for more than a couple of minutes without having to stop to catch my breath. Then just getting up to walk to the bathroom, I was having to stop and catch my breath too.
Now, you weren't on oxygen or anything like that. You were just feeling short of breath on room air.
No, if I would stop and rest, I was okay. As long as I was sitting in the bed, I was fine, and until I started to have a conversation, then I would get winded. And so meanwhile, I was waiting for my test result. They had told me 24 to 48 hours. And then I started, hearing these stories about how Mayo was totally overwhelmed, that it wasn't just New Orleans sending all their tests to Mayo, but it was everywhere in the country was bombarding Mayo, and that Mayo couldn't handle this volume, that they were actually sending these tests elsewhere because they had put this test online and then they couldn't handle the volume coming in. So it wasn't until day 6 that my test result finally came back. But at that point, I was no longer having so much of the achiness and the sore throat. I was just having this cough and shortness of breath. And so when the urgent care doc called me and said, great news, your test is negative, I didn't really feel like it was great news.
Mm-hmm, right.
I was like, okay, well, if it's negative, then, why was I short of breath while I ate my dinner tonight? So it was kind of confusing to me. And then the other reason it was confusing is because I was like, well, all right, I've been isolating myself from my kids. It's getting harder and harder to stay isolated here. My kids, they had just started their distance learning that week. And so they had done a pretty good job getting online, but they had questions coming up. And so they'd peek their head in the room. And so at first they're pretty good about like peeking their head in, but they started kind of inching their way into the room a little bit. They'd stand in the doorway and then they'd take a few steps in. I'm like, back up. But then I get a negative test result. So I'm like, well, I don't know, can they come in a little bit further? Like, I'm not coughing on them. They wash their hands. I'm wiping down things. I don't really know what to do with that. So it was a little bit harder, but I still had these symptoms. And I was talking to a friend of mine who was one of the head infectious disease doctors at my hospital. And she's like, no, treat it like a false negative. You need to stay on self-isolation. My kids, they're older. They're like, your test is negative. Why can't you come out? I'm trying to explain to them about the possibility of false negative. So it made it kind of tough. And then my coworkers too, my coworkers were like, yay, it's negative. When are you coming back? And
we've got a shift for you. Right?
Yeah. So it was a little bit tough. But then, I went to see my doctor. I was like, okay, I'm not going to doctor myself. I'll go see my doctor. I went in, got a chest x-ray and some blood work. That all looked good. And then I did an ambulatory pulse ox with her, and my pulse ox dropped to 92%. So I was like, maybe it's time to get a pulse ox at home and kind of monitor.
Right. And your chest x-ray showed?
My chest x-ray was clear. My chest x-ray was clear. So that was reassuring. But I was a little bit scared by this pulse ox dropping. I had so much time on quarantine to read all this stuff. So I'm reading about, all these doctors getting sick and all these nurses getting sick. And then I'm reading about this kind of bimodal presentation of the illness and how people, people get sick either in the first few days or they get really sick kind of on, day 10 to 12. And so here I am, day 7, and I'm still really short of breath. And then my husband picks me up a pulse oximeter at CVS, and I'm picking up pulse oxes that are kind of positional, but when I'm lying flat, I'm getting some pulse oxes that are 89, 90%. When I'm lying flat or if I'm slumped over in bed. And then I sit straight up and it comes up to 97%. That kind of scared me a little bit. But then around day 11 or so, I get this weird pain under my right scapula that feels a little bit pleuritic. And I'd been talking to all my medical friends, they're like, are you sure you don't have a PE? And so then all of a sudden I'm like, okay, which kid is going to come in and find me dead in my bed the next morning? And I'm like, okay, I know it's not my oldest because she doesn't check on me in the morning. She just comes down, gets her breakfast and goes upstairs to get on her online school. I'm thinking it's going to be my youngest or one of the triplet boys. They come check on me. So I go up and tell my husband, I'm like, you need to come look at me before you go to work the next day. And he's like, are you worried you're going to die in your sleep? And that was like, that night was the night that I was the most scared. That I was like, I'm scared one of my kids is going to come in and find me dead. So the next day I went back to see my doctor. She actually did an echo on me. She checked a D-dimer, and those all came back looking okay too. But the other thing about getting a positive test is you can rule out these other things, make sure I'm not developing heart failure, not developing a PE, which is what she was ruling out with those things. So it was kind of scary then. Yeah,
that is scary. I mean, you're right. They've talked about this bimodal, I guess, time course where people initially start out with all the myalgias and maybe cough and a little short of breath, and then they start getting a little bit better. And then around day 10 or so, then they can actually start heading south. You were ill all before a lot of this discussion about hydroxychloroquine and azithromycin.
Right.
Did you use any of that stuff at all?
I didn't. And, I have so many family members in the medical field. So I had a lot of people saying, like, you need to get on this. You need to, why aren't you taking that? And so,
right.
I talked to my doctor. I talked to this ID doctor, too, about it. And they were like, no, don't do it. Too many side effects, too many questions, just don't worry about it.
Right.
Your case is so mild. Plus, I didn't have a positive test. I think if I had had a positive test, then maybe they would have considered it in me. So I don't know. That's the other thing is that I had a negative test.
Right. Heck, there's people out there taking it prophylactically from what we
Yes, there are.
It's really not a good idea.
Yeah.
And then the other thing that people are talking about more recently is prone positioning when even in the people that are symptomatic who are awake and not on the ventilator. Did you happen to, just out of curiosity, notice any changes?
Yes, of course I tried that. I was reading everything. I mean, that's what I was, so one of the things I tried to do is like put my phone down, like get away from the social media and stop reading all this stuff. But no, I read about that. I tried it. I think I noticed a difference in my pulse ox when I was prone. Then, it seemed to go up when I was sitting up. It seemed to go up when I was prone. So I don't know how to make sense of that since my chest x-ray was normal, but I don't know. It did seem to improve when I was lying prone as well.
Yeah, and most of us have had flu at some point in the past, but you don't typically hear about shortness of breath with the typical flu the way we're hearing about with this COVID.
No, I have never had shortness of breath like that. That's why I don't know what else this could have been for me. Yeah, and I did actually have the flu this year. I've never had the flu. I thought I had it until I had it in January. It was awful, but it was a different kind of awful. It was like high fevers and achiness and not this shortness of breath. This was like, if I can just breathe normally again, if I can just, walk across my house, walk up the stairs without having to stop to catch my breath, I'll be happy.
Yeah, so, that's scary.
Yeah.
Now, Liza, you've talked a little bit about the process of being quarantined and also physically how you were feeling, but offline, we had also talked a little bit about kind of the emotional impact of being quarantined. Can you talk about that just a little bit before we get into these testing issues?
Yeah, so it was a little bit stressful. I realized that it was putting a lot of stress on my family. And, I mentioned that I was getting kind of anxious being in self-isolation and reading everything that I could get my hands on, as well as fearful about actually being ill. But in addition to that fear and anxiety, there was also this incredible guilt that I felt about being so helpless. My husband was basically left on his own to manage the household, although we were trying to get the kids to, do some chores, but, that was difficult. But so, my husband, in addition to worrying about what was going to happen with his own private practice, which is basically a small business, our nanny was not coming. So when he was coming home from working, he was cooking dinner, he was doing the laundry, and he was exhausted. And I felt awful that I couldn't help out. And
the laundry for 5 kids, that is a lot of work. Yes.
Although there was less laundry because my kids weren't really showering, especially the boys. But yes, there was a lot of laundry. And then there was work. I was, just as things were ramping up at work, I couldn't be there. And so I felt guilty that I couldn't be at work. And so it was this pretty awful feeling that all I could do was lie in bed alone in this little room. It just really wasn't a good feeling.
Well, fortunately you're out of it. And I guess you always have to be careful what you wish for, because you're getting thrown right back into the fire now.
Yeah, I'm very excited to be thrown back into the fire, though.
Yeah,
I'm very grateful. You don't realize how nice it is to be able to breathe. And like I said, I was reading so much on my phone, and all these people saying you take for granted this time with your family, and I didn't have that when I was alone in my room. And so now I'm truly enjoying this time with my family, and that's really nice.
Now, what was the follow-up from your illness standpoint?
So my doctor did swab me a second time in her office. And
you're still waiting on that?
No. No, and that was once my hospital did have the test. That one came back more quickly. That one was negative also. In the reading that I did in preparation to talk to you today, I saw somewhere that somebody's recommending really 3 tests is the way to go to really improve your clinical sensitivity. In terms of getting a good sample, it's really operator dependent too. And the first time that the nurse took a swab on me, and I mentioned that it was not uncomfortable at all, it really needs to be an uncomfortable sample. And when my doctor did it,
pretty deep.
Yeah, when my doctor did it, she's like, "I'm going to have you lie back on the bench." I'm like, "Why? Are you scared I'm gonna try to run away?" But I mean, having somebody lie back so that they can't back away from the swab is really a good way to do it. But it was really uncomfortable. She went back there for several seconds on both sides.
Wow.
And it brought tears to my eyes, and I had pain in the back of my nasopharynx for the rest of the day. So she for sure got a good sample, but it was still negative. That was on day 12.
Yeah, we've had folks in our department who had a negative in-hospital test, but I guess it was just routinely sent off for confirmation to the state lab, and that came back positive. And so I also have heard of other people talking about the need to get 2 or in some cases even 3 tests before you can be sure. And that sure as heck throws a huge wrench into whatever your plans are about, can I come out of the quarantine? Can I go back to work? Although nobody's working. Most people aren't working nowadays anyway. But that leads us into this discussion of test sensitivities and specificities, I guess. And I guess with all your quarantine time, you did a lot of reading on this also. Well, tell us a little bit about what you have been reading about with regards to the test sensitivity and the utilities of the testing.
Yeah, so that's the thing is there's not a whole, just like everything with COVID-19, right? There's not a lot of research out there because it's also new, but I think we've all seen that there's a lot of anecdotes out there, and we've probably all heard, just like you mentioned, the one that there's a lot of cases that everybody's heard about or that you may even know personally that fit the clinical picture of COVID and then test negative. And if you're on Twitter or Facebook, you've seen stories too. And then there was an opinion piece in the New York Times published on April 1st that Dr. Harlan Krumholtz, who's professor of medicine at Yale and director of the Yale New Haven Hospital Center for Outcomes Research and Evaluation, he published that was talking about the poor sensitivity of the test. That was entitled, "If you have coronavirus symptoms, assume you have the illness even if you test negative." And one of the more famous pieces of anecdotal evidence, I think, is that Dr. Li Liang, the ophthalmologist in Wuhan who first realized there appeared to be a cluster of these SARS-like cases and sounded the alarm at China, the one who eventually died himself of the disease, he had several negative tests before he had a positive one.
I didn't realize that.
Yeah. He had made a post on January 30th, this is according to the BBC, that read, "Today, nucleic acid testing came back with a positive result. The dust has finally settled, finally diagnosed." And he posted that from his hospital bed. He died on February 7th, so 8 days after he made that post. So there's not much real evidence about the true sensitivity of this PCR test. There was a study published in the journal Radiology February 26th that reported the sensitivity to be about 70%. And this was a study where they performed chest CTs on patients with positive tests and negative tests, and they determined that there was a false negative rate based on positive CT findings. Then there was this study in JAMA on March 11th where they took different tissue samples from 205 patients that were known to be COVID positive and found that bronchoalveolar lavage fluid specimens showed the highest positive rates. Those were 93% positive, followed by sputum, and nasal swabs only had a 63% positive rate. Those were patients that we already knew to be positive. So those are really the only studies that have been published about it. When I was reading about it, I found that there's a lot of information out there that if you look at all these different tests that are listed on the internet, you'll see a lot of them boasting, like we have a 96% sensitivity or 98% sensitivity. And what you really have to look at specifically is whether they're talking about the analytical sensitivity or clinical sensitivity. So a lab can say that they have a really high sensitivity rate for their test, and they're actually talking about the lab sensitivity. That's the analytical sensitivity. So how good the lab is at determining whether the virus is actually there in their sample. So when they spin it down and really test for it in the lab, that's their analytical sensitivity. But that doesn't really do much good to those of us who are working clinically. We want to know the clinical sensitivity test because that takes into account all the limitations of the test. And so that's talking about what's the viral load? Are we testing at the right time? The operator-dependent nature of it and that kind of thing. And that's when we're saying, the sensitivity is really closer to about 70%.
That's really interesting. I don't think anybody's I haven't heard anyone talk about that distinction, but you're right. And just your discussion of, putting that swab way back in the nose and how much of a difference there is just in terms of the acquisition technique makes a huge difference also, and people don't really talk about that.
Yeah, so there's how the specimen is collected. There's also how the specimen is transported or handled. It definitely can be affected about when during the infection the specimen is collected. So if you collect it too early in the course of illness, the viral load may not be at its peak. So, I was reading this and I was like, well, that's probably what happened with me, at least with the first sample. Certainly it was the collection, and it was the very first day of my illness. I don't really know how to explain the second sample, although, it still could be viral load. I guess if it's a mild case, I'm not really sure. But yeah, there's a lot of different issues that kind of come into play. for sure.
And on the news, we've been hearing about recent point of care testing and just quick finger stick testing. And I think in general, the theme that we're hearing also is that the faster the test, the more convenient the test. Unfortunately, the lower the sensitivity also.
Yeah, I haven't found anything about that. I think that it's still all, going to the same PCR kind of testing. So I think that the analytical sensitivity may still be the same, but I'm not sure about that.
Sure. And even then, these point of care tests that I've been seeing on the news recently are still not at all easily available to 90% of the people out there.
No, probably not. I just wanted to bring up, that kind of brings into question, what's the solution in terms of, if there is such a high false negative testing rate, then what's the answer for that? So I think, just like with anything in emergency medicine, you need to use your clinical judgment. You don't throw your gestalt, your clinical acumen out the window. If you have a patient with a history consistent with COVID, they're hypoxic, they're febrile, they have patchy bilateral infiltrates, maybe they have some of the lab abnormalities these patients are showing, they have COVID and they're false negative, so you keep them in isolation. Or if you're discharging them, you need to tell these patients that they're likely a false negative. They need to self-isolate at home regardless of the negative test. You treat them like they have COVID. So I think that brings up the question with these patients that are being discharged, do we actually need to test them?
Exactly. Yeah.
So, I think there's arguments for both sides. You could treat all symptomatic patients like they have COVID and not test them. But I think the argument for testing them is, imagine you have two patients come into your department. One you test for COVID, it comes back positive. The other one comes back negative. But because of their symptoms, you recommend self-isolation for 2 weeks. They both have children and a significant other at home. Which one of those patients is going to be better at 2 weeks of self-isolation? Obviously, the one that has the positive test result, Yeah,
that's true.
It's going to be easier for that patient to follow important discharge instructions if they're going home saying their test result is positive. That's just like I found with myself, having, especially after my second result came back negative, I was being told at that point by the infectious disease doctor that I should be self-isolating until I was 3 days symptom-free. I didn't feel that I was symptom-free probably until about day 20 or 21.
Wow.
And I was not self-isolating at that point. I mean, I'm not hugging my children, which is sad. Not for my kids, my teenagers, I don't think they could care less that I'm not hugging them. But it's sad for me, my 10-year-old. But yeah, I mean, and my husband and I decided for the duration of this that I'm going to stay in this room. We're coming from two different hospitals, and God knows what we're coming home with. But other than that, I mean, I'm out in the kitchen, and the kids they're not responsible for all the chores that they were before. Although I still have taught them some personal responsibility, and I think if there's any silver lining to this, that what my 13-year-old learned how to mop, and my boys have learned how to fold clothes.
You've got to find silver linings in all of this. You've just got to.
But yeah, I think I kind of went off on a tangent there. But I think that that is one argument for testing, is that those positive test results will convince some patients that would otherwise not self-isolate to do so more stringently.
Right. And it might get your kids to learn how to mop also.
Yes, exactly.
Well, thanks so much, Liza. It's great to hear from you. It's great to hear that you're back to 100% also. And hopefully this disaster that we're all facing is going to gradually ease up significantly. I'm not sure if life will ever get back to normal, but hopefully it'll get a lot closer to normal than where we are right now. So thanks again. I hope to get you back on the EMCast for any other topics that are of interest to you in the near future.
I would love
Thanks
that,
for your time.
Amal.
I really appreciate it.
Thank you.
All right. Well, to finish things up for this month, we're going to go back up to New York, and we're going to speak with one of our other graduates, Dr. Adam Brenner. He is working as an intensivist at the Mount Sinai Brooklyn Hospital or Medical Center. And he is right in the thick of everything that we're hearing about on TV and with all of this COVID-related stuff. And Adam was actually interviewed by a New York magazine about his experience, and it was written up, and that's what caught a lot of our attention. And so I wanted to make sure to get him on the EMCast as well. Offline, Adam and I were just talking a little bit about the stuff we're hearing in the news and we see a lot of pictures in the news, but not necessarily getting truly an insider view of what's going on. So, Adam, I wonder if you could just tell me what your typical day or week is like working in the ICU in the middle of this COVID disaster that we're all trying to deal with.
Sure, Dr. Mattu, thank you so much. Yeah, it's been a very overwhelming and crazy experience, for the past few weeks or so. The ICU care is, quite overwhelming. We're seeing so many sick patients that we have to cover and take care of. This includes our normal 12-bed ICU, which is completely full with COVID-positive intubated patients. An additional 12-bed ICU that we opened up using our surgical space and PACU space upstairs. And then, of course, at any given time, there's probably approximately 15 or so patients on the regular floors who are intubated and on pressors that, can't get an ICU bed because of the volume.
Well, so 15 people on just a regular floor that are intubated. Yeah. That's got to be really, really stressful for the people on the floors also, in addition to you guys running around.
It's overwhelming. The nurses and staff up there are not used to dealing with ventilators and vasopressors and ICU care in general. And us having to kind of run around the hospital covering that that's probably been the most stressful thing during this crisis.
Right. And do you know, of course, we're hearing a lot about ventilators, and do you guys have enough ventilators in your hospital for all of these patients?
We have so far. We haven't had to ration any ventilators. In the beginning, we were keeping up with the ventilators, quite frankly, simply because people were dying. But since then, we've had delivery of ventilators from the state, and we haven't had any issues not getting a ventilator to somebody who needed it.
Mm-hmm. All right, good. So we're recording this on April 16th, and offline we were talking about the fact that the news over the past several days has been talking about, maybe hopefully things seem to be plateauing in New York in terms of the number of new cases. But then on the news, they always immediately follow that with the number of people that have died in New York. And it seems like that is not going down at all. In fact, I think yesterday they said it was the highest ever. Despite this apparent peaking in new cases, the deaths are continuing to just be out of control. What, in terms of the mortalities that you're seeing, can you just tell us a little bit about what that is that you're experiencing?
Yeah, of course. So we're still seeing the same number of sick, critically ill patients that we were seeing in the beginning. And we were getting 3 to 4 overhead codes or rapid response alerts an hour. Wow. And while that hasn't been every single day, for the last few days, it's actually been like that again, which is just completely overwhelming and shell-shocking for us that it came back to be like that volume.
Wow. 3 to 4 cardiac arrests per hour. That's incredible.
Yeah, it was really unbelievable. I got to tell you, it would be the same thing that we would see every time. It would be either a cardiac arrest, which would generally be the elderly population, and they would they would essentially be the ones that would die in front of you, and then the other was the rapid responses, which would be more of the 50 to 60-year-old younger patient who you'd go to the room and it would be the same thing that we would see essentially every time. You'd be looking awake and alert, looking at you, but ill appearing and tachypnic and saturating 75% or so on a non-rebreather. And we'd intubate the patients, and if there was an ICU bed, get them to the ICU, and if not, they would remain where they were on the floor and trying to give them the best care possible there. It does seem a little bit better in terms of the overall volume and in terms of new admissions, but the ICU care is still overwhelming, and the patients that are already in the hospital are getting sicker and sicker.
We've heard some discussion about patients that are on the vents who are at times even getting a little bit better, but then they ended up crashing because of cardiac involvement or cardiomyopathy. Is there a kind of a theme to what you're seeing in terms of the patients that do head downhill and have cardiac arrest? Yeah, or is it always pulmonary, for example?
No, we have a very large portion of our ICU population that has had very long stays and not quite getting better, but also not getting worse. They've kind of been stably sick in the ICU, and then all of a sudden they have an event, and we're seeing one of two things: either what we think is a cardiomyopathy manifested by kind of elevated troponins and ventricular fibrillation arrests, as well as without having any proof of the CT scan, I'm 100% convinced they're also getting acute pulmonary embolism. as well. And those are the two things that seem to be the acute, causing the acute decompensation of kind of the stable sick patient over a couple of weeks.
Right. Are you guys just empirically putting everybody on heparin then, or what are you doing?
We have been the last 10 days, 2 weeks or so, I've been putting everybody mostly on systemic Lovenox. The reason why I haven't been using heparin is because our staff has been so short. There have been days when our nurses are 1 to 4 patients, so to put a heparin drip on would just be more overwhelming for the nurses. So we've been using Lovenox. And then these patients that I think have had a massive PE, I've been giving TPA as well.
Wow. Have you had to kind of, I hate to use the word ration, but ration resources or care in terms of running the codes? Are you doing as much as you would normally do with the codes, or with these really sick patients, are you just, calling the code or terminating resuscitation efforts much earlier in anticipation of another code happening soon?
I would say that we're probably not coding the patients for as long as we might have before, for a few reasons. One being that, at the point of cardiac arrest, we think the overall outcome is going to be dismal, regardless of whether or not they get a perfusing rhythm back. That would probably only be temporary, and we've seen that. We've gotten perfusing rhythms back, but it's lasts maybe 10 minutes or so before there's another code, the patient codes again. So we have been probably not coding for as long as we would have in normal situations, but still doing the same type of code in terms of drugs and defibrillation and compressions.
Yeah, and we've heard some reports, I guess, from the Italians and also from New York also, that once these patients get intubated, if they're sick enough to get intubated, very few of them end up surviving. I think from Italian reports, they said more than 50% of patients who get intubated will end up dying. And some folks up in New York said more than 80% of them, if they have to be intubated, they don't come off the vent. Is that your experience as well?
Yeah, we've in the beginning the guidelines were and we were being told that we needed to intubate everybody early. So you see somebody and their saturation is low, you would forego using kind of non-invasive respiratory support such as BiPAP and high flow and intubate them. But what we're finding is that once you intubate someone, it's at worst it's a death sentence, and at best it's a prolonged course of agony and iatrogenic complications. And the likelihood of successful extubation has been quite low. Personally, in our experience, we've been only able to extubate 5 patients so far, which is great that we've extubated those patients, but it's such a small percentage. It's such a small percentage of what we're seeing.
Yeah. That's got to be terribly disappointing with all the training that you go through to see that happen. And I guess that kind of leads me to the next question that I have. And people have really focused a lot in the news on the toll on the patients and also the healthcare system, but maybe there hasn't been as much discussion as perhaps there should be on the toll on the healthcare workers emotionally. Can you just tell us a little bit, share with us what you all are going through in terms of having to be up there and seeing such dismal outcomes in these patients despite so much effort?
Yeah, it's truly horrifying. Like in the beginning of this, I would be walking around the hospital, going from patient to patient, and just kind of like in a trance, repeating myself to everybody that was listening. This is just so horrible. This is horrifying. I keep using that word. I couldn't think of any other word to describe what was going on. And when this first started, we didn't know. We knew that the outcomes were poor when reading reports from Italy and Washington, but we didn't really know how bad it was. And we thought that once we intubated the patient, there'd be some semblance of hope that they were going to recover. And before we knew it, we kind of realized that wasn't true. And it's just so traumatizing for us to, for us and for me in particular, to keep going to these rapid responses and looking these patients in the eye, having them holding up the phone so they can call their family, and kind of knowing, like in my head, this is probably the last time that's going to happen and they're not going to come off the ventilator. It's been really traumatizing. There's been a couple of cases that have been, particularly upsetting for us. There was, one patient that I spoke about in the New York Mag article who we put a lot of effort into doing all the right therapies for. We're a small hospital. We're not used to doing things like proning and other advanced therapies, but everyone took it on and we did it. And she was initially getting better and better, and we thought that she had a good chance for recovery, but then I think she probably developed a PE and kind of died suddenly. That was very traumatizing. And there was a case that I just found out about today who had been doing extremely well, down to minimal vent settings, awake and responsive, and FaceTiming with his family. And he wasn't able to be extubated because he was very, very weak and had a lot of pulmonary secretions that were kind of limiting his extubation. We got him a trach, and we thought that he would be able to go to a long-term vent facility, and he unfortunately just died today, all of a sudden. So it's been really horrifying to kind of deal with the patients and their families in that way.
It's awful. In terms of your work schedule, you had said in that New York Magazine article that you're working about 6 days a week, 12, 13, 14-hour days, and you have maybe a day off per week. And today's your day off, so I'm taking up your time by taking you back through all of this.
Like I said, I'm sitting here isolated from everybody, so I have nothing else to do, so it's great. It's good to talk to somebody.
What are you doing to just keep going? I mean, what kind of coping mechanisms have you found useful for you?
You're trying to, rest when possible, trying to, even when I'm working, multiple days a week, there are some days where I'm not the direct person responsible for all the patient care. Those days are much, much easier. I can kind of more coordinate things and be more of a supervisory role and kind of organizing some administrative things in terms of making sure we have the right equipment and those sorts of things. So those days are much better. Otherwise, it's just kind of speaking, can't see them, but speaking to my family over the phone and FaceTiming and keeping connected that way has been essential for me.
Yeah, you had mentioned offline also that you're essentially quarantining yourself when you're not at the hospital, and you have a wife and a 14-month-old who you haven't seen in a month. Tell us a little bit about what that has been, or how did you come to that decision, and what that's been like?
Yeah, it's just been terrible for doing that. But when this first started, we there was a few patients that we saw before the crisis really began, that kind of before it got really bad. And I was coming home and just kind of showering right away and separating from my family a little bit within the house. But when it got, so out of control, and I realized that, I was like, as a critical care doctor and an emergency doctor, we're right in the face of these patients doing high risk procedures like intubating and bronchoscopy and, other high risk aerolization procedures. So we just decided that since we had the opportunity, my wife and daughter could go to her mother's house, that this would probably be, the safest thing in our minds to ensure the safety of everybody.
Yeah.
But it's hard. I mean, it's just really hard. I mean, FaceTime and video it's not the same. It's just not the same, obviously. And it's been really difficult. And, I have, other, family members, my father I haven't been able to see. And another hard thing has been, I have elderly grandparents who are quite thankfully so far doing very well and still at home, but we don't know how long this is going to last, and kind of thinking recently that they're likely to get sick or even die of something else unrelated to COVID before I can safely see them again. So that's been a very hard realization, in all of this.
Those are definitely things that we don't really think about just watching the news, for sure. Well, my last question for you, Adam, is if you could go back a month or so, knowing what you know now, is there anything else that you would have done differently to prepare for what's happening now? And this is kind of a question that I think a lot of people are interested in who haven't hit the surge yet. There's a lot of places around the country in which the surge there is expected to happen at the end of April and early May, and they've all expressed an interest in just getting some tips. But if you knew what you do now back then, what would you do differently? Anything?
Oh, yeah. So it's a great question. I hope people can learn from our experience, because we were, both pretty much really underprepared for a lot of what happened. So, I mean, the first thing is, people have to kind of think creatively. There's going to be staff shortages. There's going to be an overwhelming volume of patients that all need beds. So to, coordinate the staffing and the opening of beds is important. We made preparations to open up an extra ICU, like I said, and we were ready, from the physician standpoint, we were ready, but when we needed it, we weren't quite ready from the nursing and staff perspective. So to make sure there's coordination between the physician leadership, the nursing leadership, and the staff leadership, including respiratory therapy, PCAs, and cleaning and transport staff. That's very important. In terms of other things, our problem never was ventilators. We were finding that this disease was just as much a disease of the kidneys as it was anything else. And in the beginning, we were having a hard time arranging dialysis for everybody. We were more short on dialysis machines and nursing staff and dialysis staff than we were ventilators or anything else. So that was, a real eye opener for us, and we just weren't prepared for the volume of patients that we needed acute dialysis for this. And then the last thing I would say is that all these things that we take for granted of just kind of being there when you go into the supply room and you look on the shelf and you think it's going to be there, be prepared to run out of those things. So what I mean by that is, things like central line kits and arterial line cables, dialysis catheters. We were just, we ran out. I mean, there was a point where we didn't have any. We were supplied very quickly, but we ran out of these things, even things like ultrasound gel and things like that you just take for granted. We didn't have for a time being, very short amount of time, and then we were able to get ahead of it by placing fairly large orders. But those are just things you never think you're going to run out of. At least I never thought we would.
Right.
Yeah. Things like intubating equipment, glide scope blades and stylets, we came dangerously close to running out of. And again, like I said, we were supplied very quickly, but just to prepare for that ahead of time probably would be helpful.
Well, Adam, I want to thank you so much for everything that you're doing and for the tips that you're providing to all of us. I know all of us are going to make it through this crisis eventually, and we'll all look forward to that day. But until then, please take care of yourself and your colleagues and your family, and we'll stay in touch.
Yeah, please stay in touch, and thank you so much for having me. It's great to talk to you. Thank you.
Well, that was definitely a sobering discussion about what's really happening inside the emergency departments in the hot zones, something that we here in Baltimore have not quite hit. Everyone says that we're going to get to that surge week next week, but we'll see what ends up happening. I'm sure many of you out there are in similar situations. For those of you that are in scenarios that is similar to what Adam described, I wish you the very, very best of luck for caring for yourself, not just your patients, but caring for yourself and also caring for your families and caring for your colleagues as well. I want to thank Josh Moskovitz, Liza Thomas, and also Adam Brenner for taking time from their valuable schedules to spend with us, teaching us a little bit about everything that they've experienced. And we will bring you more COVID medical type of information. In fact, May 1st, when we have our normally scheduled next edition of EMCast, we're going to have plenty of patient care information. We're going to talk about what I refer to as COVID on the brain, neurologic manifestations of COVID. We're going to talk about some critical care issues. We'll talk a little bit more about preparations. And if we have time, we'll talk about some cardiovascular issues that relate to COVID as well. So I want to thank all of you for joining us for this special edition of EMCast. Please take care of yourselves and your colleagues and your families, and we will talk again very soon. Take care, everyone.
Hey, thanks for listening to EMCast. And for listening to the end, here's a discount code for you. Use discount code PODCAST for 10% off each year of an annual subscription to EMedHome.com.